This episode of Beauty and the Surgeon podcast is brought to you by Let's Get Checked. Let's Get Checked is an online company dedicated to making professional health testing easy and accessible. Let's Get Checked offers fast, affordable, completely confidential at-home health tests from a range of tests from STDs, male and female hormones, and even COVID-19. Listeners of our podcast who are new to Let's Get Checked get 20% off by using our URL, trylgc.com/beauty, and be sure to use the code BEAUTY20 at checkout. That's trylgc.com, trylgc.com/beauty, BEAUTY, and be sure to use the code BEAUTY20, BEAUTY20 at checkout. Do it. Getting tested is important. It's the responsible thing to do, and you know how important I think it is to make sure you understand your labs. Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today, as always, by the very charming Dr. Jason Martin. He's a board-certified plastic and
Last week I was fantastic. This week I'm charming.
Dr.
I'm just an all-around swell guy.
How you doing?
I'm really good.
Good. We have a very exciting episode today, and I'm going to first address the thing that Nils just asked me, as if we had any audio for today's video, and we do not, because today is questions from listeners and viewers, and there are no voicemails, and that makes me very sad. So please, here's the number. Leave me a voicemail, 303-630-9038, and you will hear yourself on the next episode of Questions from Listeners. In fact, if you go back and listen to our older episodes of Questions from Listeners, you will hear actual other listeners and viewers,
which is funny,
leaving questions.
Because this channel, what we're doing, this podcast has been very successful, and it's growing exponentially, and we're getting a lot of engagement. But in the old days, we used to get the voicemails. Yep. Isn't that weird?
Yeah. Well, because you made me feel guilty.
How does
about
that work?
You're too famous now.
Yeah. They're a little intimidated because we're so over the top.
You can
successful.
also text that same number. So someone did text, and the rest of the questions are from YouTube or Instagram.
Yeah,
so
we
and
get
you can
a lot
leave
of
us.
questions. Yeah.
Follow all our social media. If you're listening to this podcast, you want to watch it, you can find us on YouTube at Jason Martin MD, and we're on all social media at Beauty and the Surgeon Podcast and at Jason Martin MD. So please leave us some questions. We love them.
We love them.
These are some of my favorite episodes because we get so used to doing what we do that we don't always know the things that people are wondering about. So this is where we find out what you guys want to know about.
What the peoples are thinking.
Yeah.
Yeah.
We have a very special, our first slide is a very special shout out. This actually came in right at the end of the year, and I didn't have a real good spot to put it in. So blah, blah, blah. One of our OG listeners sent this awesome picture that says Dr. Jason Martin, board certified plastic surgeon. And I just thought it was so funny because it's play on words, right? It's all cardboard, like corrugated cardboard.
Yeah, yeah.
I love it. And I think of a lot, my mom always used to love doing those things like in the paper where it was, you'd try and figure out what it was supposed to be. Like it would be, like above reproach or something, and like the word above would be above something else, or like those kinds of things.
So I feel like like when you do security questions, when you want to they do that, you're not a robot, you're not a bot, and they show you the little tiles of pictures, and half the time I have no idea what I'm looking at.
To show the overpass, show buses.
Where is the truck? And it's like I feel it's like one of these pictures, you have to figure it out. So.
Yep. So thank you so much.
Thank you, blah, blah, blah.
And then, so our first question, actually, our first two questions, it was kind of like these, she sent these as separate questions, but I combined them because they have very big similarities. So I'm going to read them. So have you seen any differences in healing between seasons? I'm imagining there can be quite some variations in how the body reacts when humidity, sunlight, circadian rhythm, and sleep is so important, and diet varies throughout the year. Are there any specific surgeries you don't recommend doing at a particular time of year? And followed up by, have you seen or would you think there would be any difference in healing between people living at high versus low latitudes, and any difference between surgeries taking place at low versus high latitudes? Or if someone like me flew in and did surgery at high altitude, would I want to wait a few days or weeks to adapt before surgery? So we have a lot of experience with all of this because we do surgery year round, and we also used to have an office at like 8,000 feet and an office at 5,000 feet, which to me, growing up at 10,000 feet, 5,000 feet is low altitude, whereas to someone from sea level, it's high altitude. So,
well, it's funny, blah, blah, blah goes with the latitude, not feet or meters above sea level.
Well, I mean, I think she's talking about sunlight and like other differences and diet. I can imagine those things would, based on where you were in the world. Mm-hmm.
Yeah, the basics of people that live in northern areas probably all have rickets and deficiencies. Yeah, I mean, I think it's very interesting. I'm not really sure that any of these things make that much of a difference, to be honest with you. So the only difference would be is if you live in a tropical area at sea level and then you precipitously, like within 24 hours, went up to like 10,000 feet at Leadville in Colorado and then decided to do surgery then. But even then, physiologically, your body reacts amazingly quickly. It takes just a couple days, maybe 3 or 4 days for your hemoglobin levels to go up and all the physiologic responses there is to, lower oxygen. So, and then the secondary answer to all that, at least at altitude, is just to put oxygen on somebody, or even better, put them in a hyperbaric oxygen chamber for healing. So, yeah, but it is something I've thought about. I do think that the intangibles of certain things like this, like sunlight for bruising, but also for your mind and recovery, are huge. And I always wonder if people that live in low sunlight areas like Seattle, by the way, everyone that lives in Seattle acts like it's sunny.
It's not.
Like they're trying to progress this lie that everyone tells. They're like, oh, it was a sunny day today. I was like 1 out of 30. So,
I mean, when it's beautiful in Seattle, it's gorgeous.
Beautiful.
I mean, I have lived there, so I can speak from experience. Like, yes, there are sunny days in Seattle and they are glorious. But there is also a lot of darkness and a lot of just, I don't even know what, cloudiness. So.
Yeah, what even is that? Like a mist, like a depressive mist.
Like hazy, I guess. Yeah. And then, oh my gosh, like several summers ago, we had this terrible fires. And so, yeah, it was sunny, but there was so much smoke in the air. You can get to enjoy the sun because it was so smoky. I mean, that's not Seattle's fault. But yeah, I do think I agree with you. And when I read this, that was kind of the one thing that stood out to me the most is potentially, let's say you're having non-elective surgery. I mean, if you are having, unfortunately, that non-elective surgery at a time of year when you are depressed because of lack of sunlight, are you going to heal as well? Maybe not as quickly. I mean, I think ultimately, like you said, the body is very adaptive. Like it's going to do what it needs to do. I mean, if we had to mentally control our healing, we would do nothing else, right? Like that's all we would do. I mean, I shut my thumb in the drawer last weekend. I mean, if I had to use my active brain thought.
I mean, the amount of injuries you have, it's embarrassing.
It was small.
That I would think that you had a neurologic condition.
No.
But it's just straight up clumsiness.
It's just clumsy. My middle name is not Grace. But if I had to actively think like, oh my gosh, I need to heal this wound, I mean, you would never be able to do it. So a lot of that happens without you thinking about it. So those other things.
You mean there is no like mental control of Sloverine?
You cannot Sloverine yourself. I mean, if you could, I would just Sloverine myself into stopping aging.
Oh yeah, I would
entirely. I mean, yes, I would fix that.
I would be one of those water tanks that's all dark and just thinking about I'm not getting older the whole time.
But diet, absolutely.
And I would never live. Yeah.
Yeah.
So I think diet makes a difference. I think sleep is huge, and it's really hard after surgery. Amy, you could probably go into this. You're on pain medications, and you have discomfort. Your sleep cycle gets disrupted, and that really affects people in terms of recovery, both mentally and physically.
Yeah. I mean, one of the things I think is interesting now that we do track more of these things, patients who wear, an Oura ring or use any other type of like a Whoop or a tracking device, I always warn them that in the several weeks after surgery that their HRV will be a lot lower, their resting heart rate will be higher. Those are things that just happen automatically. Sleep is, if people struggle with sleep before surgery, they tend to struggle with sleep after and vice versa. If you're a good sleeper before surgery, you might have a few nights of, kind of adjusting, but you're going to sleep well. The diet varying throughout the year. I mean, ideally, you should vary your diet to optimize recovery around surgery, regardless of the time of year. And we have the ability now to make that happen in most parts of the world. It may not be the most nutrient dense, but you can pretty much find a way to make your diet extremely nutrient dense with food that is readily available and not exorbitantly expensive based on where you live. I mean, if you live very far north, not a lot grows in the winter. But, you can get things that are native to your area and or, to your body type that are going to help with optimizing your diet any time of year. The only surgery that I would not recommend doing at specific times of year are for, and I know you love when I talk about swimming, but if summer and or winter activities are extremely important to you,
I'm quitting this podcast.
Doing any surgery,
I can't stand the incessant talking about swimming. And I actually like swimming.
Yeah.
But
so if you love swimming in the summer, I mean, our summers here in Denver are longer than they are in other parts of the state, but still not that super long. If it's really important to you to be outside in the sun and in the water, you should not really have any surgery around those times of year because you want to keep your scars as well protected from the sun for the first 6 months to a year. And also you aren't going to be able to swim for probably 6 to 8 weeks, depending on the type of surgery
most of the stuff is logical. If you think about it, if you do things in the summer where it's hot and humid, especially if you live in American southern states where it's hot and humid, maybe you don't want to do full body work. It's easier to do it in the winter time. Also, face and neck lifts, things that are more exposure. Theoretically, if you wore like a scarf around your neck,
hats, glasses,
stuff like that, it wouldn't look weird in the wintertime, maybe a little more weird in the summertime if you care about that kind of stuff. I mean, that's where the time frame plays in it. But, we always tell people just do it when it's good for you in your life. I think the seasons are just a small variable of many other bigger variables in terms of outcomes and recovery.
Yeah, same thing with altitude. There, like Dr. Martin said, your body adapts really quickly. There definitely is a benefit, for our patients who maybe, live at higher altitudes in the state who do surgery with us in Denver. They're usually feeling a little bit peppier, perhaps, just because they do.
I just went on
inherent
vacation
boost.
to ocean area.
I feel like you're a superstar.
And I was lifting weights, and I was like, oh my God, I'm Herculean.
Yeah.
It felt totally different.
Yep. I know that goes away, so
it totally goes
adapt.
away. I know.
So,
but at least for like 10 minutes, I was like, I am the man.
Yeah. We would definitely recommend if you are from sea level and are not used to any type of altitude, you absolutely should arrive for your surgery several days before. We had a patient like that this week, as from an island nation, came into Colorado several days before surgery, just to make sure you're not having altitude sickness, give your body a chance to adapt, not only to the altitude, but also to the time change, those things, so you're not kind of starting surgery a little bit behind the 8 ball anyway. So just giving yourself a couple of days to adapt. I wouldn't think weeks would be necessary. I mean, depending where you're from, several days is plenty.
Well, the board question is, if you have a patient that travels a lot before surgery, so we get 50% of our patients or so are from somewhere else, and some of those places are long distances away. And you travel before surgery, and it's a long travel, and it's a lot of sitting, you have a higher incidence of deep vein thrombosis after surgery or blood clots, which can lead to a pulmonary embolus, which is one of the few deadly things you can have with cosmetic surgery.
Any surgery,
but specifically, that's one of our big worries with cosmetic surgery. So having people come a few days beforehand, mobilize, is really important. Also, if you are traveling a lot before surgery, is make sure you get up every hour and walk around on the plane. That's one of the things we recommend. And then even further, we'll give you low molecular weight heparin or a blood thinner after surgery to ensure that you don't get a blood clot if it's a body case or a longer case.
Yeah.
Which we did on that patient that you just referred to.
We would have anyway with the extent of that surgery.
Yeah.
But yeah. So there are workarounds for all of these things. But I thought that was just such a great question. And so, blah, blah, blah's questions are always so thoughtful and intuitive.
She's like a plastic surgery philosopher.
Yeah, no, they're awesome. So
modern day philosopher, blah, blah, blah.
Yeah. So thank you for the play on words photo and the awesome questions.
Yeah. I am board certified.
You're
Cardboard
certified. Cardboard certified. All right. This one actually was from YouTube. This is from Shannon on YouTube. And I thought this was such a great question because, I answered it right away, but I thought it would be great to go into more detail about. It was short enough. When people have a deep belly button after dramatic weight loss, do you shorten the belly button tunnel? I am experiencing diffiefulties with how deep it is after losing 125 pounds.
This is such a good question.
Yeah. So the way
because I struggle with it all the time in the operating room.
Right.
When you gain weight. Did you answer that to her?
I did. And that's what I said. Let me just briefly just cap what I said. And because it was, there's a lot here, but the shorter answer to this is no. But that it's what's making your belly button tunnel seem deep is the amount of excess tissue around it. It's not that your belly button is deep in, it's that there's excess skin over it. So we don't shorten it, that stays attached, but we do have to remove the excess above.
Yeah. And I will tell you, the stalk of the belly button does get longer with severe weight gain.
Stretches.
Because it stretches it out over time. And there's only so much that belly button can tether. So people that have had notable amounts of weight loss, in this patient, I think, 125 pounds, the stalk of her belly button, right, is going to be really long. So you have to address that during surgery. You're not going to keep it that long after the tummy tuck. So you do bring the belly button stalk down, right? You imbricate it, or whatever the layperson term would be. And that's pretty difficult to do. And it's always a guessing game how much you do that in comparison to the thickness of the flap. People lose 125 pounds, usually still have thick flaps. They still have fat on their bellies. Rare is the time that they're like devoid of fat. So you can't bring that stock all the way down. Again, I'm showing people on the podcast with my fingers.
You're still saying the words.
Am I saying the words? Am I doing good, Nils?
Yep.
I'll close my eyes.
Okay, just close. Yeah, I'll close my eyes too. And then you bring that stock down, and then you inset it. Now, belly buttons themselves for tummy tucks is one of those signature things that you do. It's not very hard. I'd be happy to share my secrets with everyone about how I do my belly buttons, but you want to invert the belly button. You don't want to make it an outie. A lot of times people with massive weight loss will go to a plastic surgeon. The surgeon doesn't want to deal with the long stalk, and they just keep an outie, or they don't.
Or they just don't even use the belly button at all. Like they just cover it up. Like if you're getting.
I've seen that. We've seen that. We've actually seen that where
Yep.
they just remove the belly button completely.
Well, they don't. I mean, they they don't pull it back through. They don't remove the belly button. They just leave it inside, essentially.
Well, but they don't leave the skin inside, but they literally don't have a belly button.
Yeah, they just take it all. They
Which
take
was
it with the skin, essentially.
one of the weirder things to see. We had a patient come in where they just took the belly button out. It was for some reason. Do you remember what that reason was? She wasn't of massive, she didn't have massive weight loss, but they removed her belly button. And it, like, you're looking at her and you inherently knew something was wrong, but you couldn't put your finger on it. That was what the funny thing was.
Yeah, because it's like a Barbie doll. There is no belly button.
There's no belly button.
Yeah.
I know.
Yeah.
So it's hard to handle it. I think this is a very, very good question. But yes, if your stalk is long, you're going to have to somehow shorten it, but you're not going to cut it because that's the blood supply to your belly button itself. The other option is to remove the stalk, keep the skin of the belly button, and then skin graft that down to your abdominal wall and then bring the flap down to that. That would be a disaster. But you could do that, and I'm sure in severe cases people have done that.
Yeah. I mean, she was talking specifically about the distance from the skin to the belly button, not the belly button to the muscle wall. So was asking to shorten that. And
I took it totally differently.
Yeah. So that's why I
just took it 100% from a surgeon's mind.
Right.
Yeah.
But the same thing is true. And that's what I said in my answer. Like, there's no need to essentially do that. When we pull the skin down, we bring the belly button up to meet it, which is you're removing that, thickness of skin or that area that's causing that tunneling. You're removing all that skin. So when you pull the skin taut, like Dr. Martin said, there's inherently going to be some stretching of the belly button itself. However, and you can't pull it all the way back down to the fascia, right? Because the skin flap that's coming down over it is going to be thicker. But we match it. Like, we bring the belly button and the skin to match the thickness. And
I'll thin out the flap in the area of the belly button inserting. Take fat away, which I won't do in the whole flap. You watch was that the most recent one, Tummy Tuck Myth episode? We talk about that you can't take all the fat away from the abdominoplasty flap. And then sometimes afterwards we'll do liposuction, but around the area of umbilical insetting during the surgery, I'll defat that. So there's not a lot of distance to bring the skin down to the belly button skin part and secure that to the fascia and 4 quadrants around there. So yeah, it's a hard problem. And some of these stalks you'll see, they're like an inch long, which is crazy because most stalks would be,
centimeters,
a quarter of an inch. Yeah.
Millimeters.
So that's how much it's stretched out over time.
Which isn't surprising. I mean, when skin stretches, stuff's got to stretch.
Inherently, with massive weight gain and weight loss, they inherently have umbilical hernias, which makes it harder. You're always kind of working around that. So the belly buttons are always the tricky parts for people with massive weight loss.
Yeah. But just know that when/if, Shannon, you decide to get a tummy tuck, that would be addressed in those two kind of combination of ways.
Yep.
The tunnel itself is not really the problem. It's just that there's too much skin. So
good question,
Yeah,
Shannon.
it was such a great question. Yeah. Awesome. All right. So we're going to take a quick break. Come get a word from our sponsors. We'll be right back.
See you soon.
Dr. Martin, I'm super excited to talk about our sponsor for this podcast, Let's Get Checked. If you've been a listener of our podcast, you know that we have never had a sponsor before, and it's because we're an educational podcast. We're not looking to monetize, and we also would never recommend something that we didn't believe in and or use ourselves.
So basically you're saying we're very choosy.
We're very choosy when we come to our testing, but Let's Get Checked really aligns with our values. We talk a lot about monitoring your blood values of certain things. We talked recently about vitamin D serum levels. We talk a lot about hormone levels, and it's hard for some people to get to a lab, or you're afraid of the blood draw, or just, you're concerned about confidentiality. Like, you have a lot of concerns and you just don't do it. Let's Get Checked makes it super easy because it's completely confidential. You do it from your home. So there's really no excuse not to do it.
Yeah, and we did it recently. Both Amy and I did it. She looked at her women's health, basically her hormone levels, and I looked at mine on the men's health side with testosterone. It was very simple. You go online. Their online interface is really easy to use and good. We got the testing kit very quickly. And the test itself, actually doing the stick, you do a stick on the end of your finger, is not hard to do. It only took about 3 to 4 minutes. You put it back in a sealed envelope that's confidential, goes back to them. You get your results in 2 to 5 days. It's really that simple. And the best part is it's about empowerment, about you taking control and trying to do things that are positive for your health and life. And this is one way to do it, literally from the comfort of your own home.
Yeah, so they offer a wide range of tests. So they do men's and women's hormone panels. They do a full panel of STD testing. They also are now offering a COVID-19 test at home. So there are a lot of other just basic blood levels that you can get tested as well. And one of the things that we always say is you can't track what you don't check. So you might not know what's normal for you in the future if you're not checking it now, especially as it relates to hormones. And men's health specifically, I feel like is a little bit undertreated. I mean, sperm counts are dropping by a large percentage in men these days. Most men struggle at some point in their lifetime with low testosterone.
And those men do not know what the symptoms of low testosterone are. Depression, anxiety, sleep problems, osteopenia or loss of bone, loss of muscle, and something we treat all the time, gynecomastia or male breast growth. These are real problems that can be improved or treated with testosterone. And these men do not know their levels. It's so easy to get checked. And this is why we're so excited about the sponsor.
Yeah. And Let's Get Checked is a completely CLIA certified lab, the CLIA lab. So they're a well-established, completely safe lab to use. You do get contacted after, so you get your results. I got a text at 4:30 in the morning, which I loved, that my results were ready.
And we're both up at 4:30,
yep,
so that was good.
Super excited. And you have access to not only a nurse, but also a physician. So a physician does review your results, and it gives you a little breakdown of like where you're sitting on those levels. Dr. Martin's had even comparisons of like where two of the levels should be in relation to each other, which is a really important thing to note.
Right.
Just being within the normal range is not always enough. So it really gave more information than that. You'd still want to, of course, reach out to your own doctor if you needed some additional assistance with these labs or you did see something that was concerning. We didn't, thankfully, so that was good.
Yeah. We were both good. This podcast is about empowerment. It's educational. In my private practice, I'm a board certified plastic surgeon. We are all about empowerment, and this is one way to do it. So we're very excited about the sponsorship, and we're looking forward to using it for our patients moving forward.
Yeah. So as a listener of our podcast, if you're also a new time user to Let's Get Checked, which a lot of you probably are, we do have a 20% discount code. So you do need to go to our specific URL, and it is linked in the description box below, but it's going to be TryLGC. So TRYLGC, like Let's Get Checked.com/beauty, BEAUTY. And you'll need to use the code BEAUTY20 at checkout. Beauty again is BEAUTY 220. And you can pick a test, like any test you'd like, put in our code and get your test shipped to you. Getting tested is the right thing to do. It's let you know where you're at and what's responsible.
All right. Well, let's get tested.
Let's get tested. Let's get checked.
Let's get checked.
We're back. I find it somewhat not funny with us that in February, when it's like been -12 for the last 3 days, we're already talking about Halloween.
Yes.
Like that's how we roll.
Yeah, 100%.
Clearly we have our season priorities.
Yeah, I mean, I'm like really hating winter now. Like
it's been real cold.
I have a real problem with it.
Yep.
So I wish there was a concierge you could call up and just change the season. Like,
you just got back from a tropical vacation. So,
of course.
Yeah, you don't get to complain about the weather. I've been here dealing with it the whole time.
So I went to a tropical area, and the people there were like super nice. Just really such a vibrant culture. And they were like, "So what's snow like?" And it's just such a interesting conversation.
Tell
I'm like, "Well, it's cold." Yeah,
it's inconvenient,
and it's annoying, but I'm sure, it's probably looked at with a lot of intrigue, and it's probably. If you came from primarily a beach area and you'd never seen snow and you went to the mountains, it has to be pretty remarkable.
Yeah, well, think about the first time you saw the ocean, if you remember that. I mean, it's the same thing.
I don't remember.
Yeah, snow is inconvenient. If you haven't experienced it, I will tell you that now. What is snow? It is inconvenient in all aspects of life. It's beautiful and all the other things, but more than anything, it's inconvenient.
It is beautiful.
Yeah. All right, let's get back into our questions from listeners. This one is from YouTube David, not Dave, not YouTube Dave. This is not medical student Dave. But this was such a great question. What are your thoughts on the incision-less otoplasty to bend back the upper helix area? And I did answer this, David. But I thought this was such a great question because, what I succinctly said to him was that absolutely, if you have a very mild need for an adjustment, yes, that suture, the only issue is when you're doing it, in a very minor ways, it could be visible. The type of suture we use could be visible through the skin. So, Dr. Martin, what are your thoughts on that?
Well, there's for a standard otoplasty, we make an incision in the back of the ear. We open, expose everything. We do these suture techniques, like one of them's Mustardi, Mustarde. You can look that up. As a French dude, not alive. Nobody's alive anymore that created all these surgeries, Amy.
Well, it was a long time ago.
Yeah.
These old anatomists, it's like trying to find Cooper, who named Cooper's ligaments.
Yeah.
Like, these people don't exist.
We do conchal sutures and, a lot of these suture techniques. And you can even do abrasion techniques on the cartilage just to reform the ear. And then in the conchal, the bowl, the area of your ear, if you go into behind your ear and you feel that kind of fullness of the cartilage behind, that's the conchal area. You can take that out and suture it down. So there's a lot of ways to do otoplasty. Otoplasty is one of my interests. It's not a common procedure. I was taught by a craniofacial surgeon, Dr. John Pauly, an amazing surgeon, and we would do a lot of these procedures there. So I'm definitely very competent when it comes to otoplasty. But I will tell you that, there's different ways to do it depending on the presentation and exactly what Amy just said. And you don't always have to do these suturing techniques. You don't have to do these open incisional techniques. There are, small incisions you can make and do some abrasive techniques on the cartilage itself to result into the outcome you want. And it's rarely the prominence of the ear or the angle from your head to the ear itself. It's more related to the upper part of the ear, which is called what, Amy? The helix, right? So the helix.
Upper helix.
Oh, is that what you said? Yeah. Okay. I didn't even read the question.
Or listen to me read it.
Which, by the way, was half my problem in standardized tests. I'm like, I know the answer. Okay, B. In the upper helix area, there's cartilage ridges there that have names. I'm not going to go into all that stuff, but that can be effaced or not developed over time. And that can lead to the upper ear being more prominent. And you can actually create those ridges with sutures or with other techniques. And I think that's what he's referring to. So there is no true no incision otoplasty. There's going to be some sort of invasive structure.
I know. So I think people think like there's no incision if all you've made is a very small incision.
Right.
I mean, could you make a little teeny tiny poke incision?
Is there something that David's referring to, like a new technique where they do something external?
No, they call it incision-less otoplasty. All they're doing is putting suture in. I
Yeah.
mean, they're still making a tiny little hole, but they're not, I mean, this is what I mean. This is where people, it's like you call liposuction incision-less.
Right.
Is there still a way to access the body? Yes.
Yeah.
So is that technically an incision? Yes.
Right. So you can do it with, if I'm inferring from what this question means, like you can do it with suture material, or the classic way is actually to make a really small stab incision and stick a device in where you kind of really braid or thin down that cartilage in the area that you want it to turn or shape. And which would be along the normal folds of the cartilage that should be there, which usually are not with prominent helixes. So, yeah, it's an interesting question. I have no problems with that. It just depends on your presentation. If you have a problematic angle from the ear to the head, okay, how far your total ear sticks out from your head. Normally that's a little more acute if that's a real prominent angle, right? So you're looking at yourself, then some sort of less invasive technique or not, quote unquote, non-incisional technique is not going to be enough. Yeah.
It's so true. And, my cue in here was bend back. I mean, if you truly have like almost like the elf ear deformity where it's like completely bent forward, like you're never going to bend that back with just sutures.
There's tons of different deformities. This question would actually be better if we had a bunch of plastic surgeons sitting around. We could trade stall ear deformity. There's like literally 10 of them. Every time I take the in-service exam every year for plastic surgery, I have to remember all these different deformities. And then there's even more severe deformities like microtia or undeveloped ears that have prominence to them. But for the standard person, it's usually the lack of development or overdevelopment or weird development of the cartilage, specifically in the helix. And what you do with these less invasive techniques is you try to reshape that helix in a way so it looks, the cartilage itself lays like normal cartilage in the standard patient without prominent ears.
Mm-hmm. One question that we've never had asked about otoplasty that to me seems like something that people would ask. And I mean, the number of consults we've done for otoplasty, no one has ever asked this, at least not when I was in the room, if it was going to affect your hearing. Because the ear is such an amazing thing, and the shape of our ear is not for nothing. It impacts how we hear. So has anyone ever asked you that?
No.
Yeah, I'm surprised that no one's asked me that either, ever. And I mean, does it? There we go. Let me ask you, Dr.
I don't think so too much. So. You have the external ear and then the ear canal, and you have the middle ear. And hearing problems are usually middle ear problems, related to all the fine. Do you remember all those things in the middle ear?
All those little milia, or not milia.
The ossicles.
Yeah.
Yep. It is. If you want to get weirded out and like truly amazed by the human body, go look at the middle ear structures.
Goodness,
yeah. Every time I look at that, I'm like, they're microscopic and they're like super detailed and they all do different things. And
Well, have vertigo and you'll do a deep dive into the ear and be shocked.
Like you've had that problem. Like my wife has too, the benign positional vertigo.
It's awful.
It's terrible.
And to think that can come from inside your ear is
And the power of that onto your whole body.
Oh.
And it's a super duper small area that's very complicated.
With fluid that moves.
Yeah,
I mean,
it moves spatially
Yeah.
and three-dimensionally. So
Your ears are pretty awesome. So great question, David.
I feel like we're looking at the stars, thinking about philosophy and
Right?
history of the world. You know?
I bet you're.
Did you remember when you were young and everything was so amazing? You know, like,
It
oh,
is.
I
It
wonder
kind
what-
of is,
I
though.
wonder what that planet, how far away is that? It's so amazing.
You know
That's
what-
kind of, I still think that about the middle ear.
That's because we actually have to think about those things. See,
Now,
people don't have to
when it
think
comes to the
anymore.
external stuff that I work on, I'm like, yeah, whatever. You know, great skin. Okay.
That ear is
whatever.
pretty cool.
Yeah, ear's cool.
Yeah. All right. So our next one was actually a text, and this was from Patricia. She texted the number that I'm having Nils put up again
Right here.
halfway through 303-630-9038.
No one's going to leave a voicemail. It's
No.
okay.
You know what is interesting though?
Please don't leave a voicemail because it's just fun for me to torture Amy about that.
Yeah. Send me a text. So
Reverse psychology.
this was from Patricia. Is a healthy 72-year-old woman too old to have a thigh lift?
What is it with these ladies that are all too old? You know, they always think they're too old.
I have saggy skin at the top and pockets of fat by the inside of my knees. And how do you poop when you can't sit after surgery? I've watched all your YouTube videos and haven't heard the answer to either. Thank you.
Did she watch the video where we're going to have the toilet? How do you say it when you're not from Kentucky, please?
Toilet. We don't add an R.
There's no R in there.
There is no R in
it's
toilet.
Toilet.
Yes, toilet.
It's a toilet extender with our logo on it and my name, but I would like the name in very prominent letters, maybe hot pink.
Yeah, I don't need to get in on that.
Yeah.
That can be just you.
That's how we're going to make serious coin.
So I thought, I'm sorry, Patricia, I think we did address this in an episode, or at least we talk about it, how challenging it will be. I mean, maybe that's...
I just saw our patient today. We did a medial thigh lift and a posterior body lift or buttocks lift. And it was difficult for her to go to the bathroom. She, the nurses at the hospital actually got her a toilet extender, and it actually worked really well. Plus, in the hospital, it's they have those railings next to the toilet, so you can kind of hold on to that and lower yourself down just enough.
Yep.
I
And
think
then,
between those two things, it was doable.
yeah, the rentable toilet extenders also have handles on them, and that's part of what does really help. You can actually get they call it like a female urinal, so you can stand to urinate, which is great. So, just to limit the amount of times you have to even attempt sitting, and then the times when actually, you do need to have a bowel movement, having the toilet brought up higher, so you're not having to bend at that extreme angle is definitely going to help. And also, you can kind of hold yourself up a little bit to support your weight. You just need to, figure out a way to limit your tension on the incision line, and that usually comes down to raising the seat up to meet you more.
So we have a thigh lift video, and it talks about medial thigh lift, which it sounds like what you need, as opposed to a full linear thigh lift, which would go from your knee to your groin area. Medial thigh lift goes from your pubic hair area, passes next to your labia, and then goes back to the crease at the base of your butt. And that's what we did on the patient recently. You do liposuction with that. And you close it, and the closure is really important because, Amy, what's the biggest problem with these kind of procedures?
Dehiscence
And spreading apart.
Stretching.
Even Nils knows. And
Yep.
Nils is not a plastic surgeon.
tension. Well, there's just a lot of tension.
You probably know more than most fellows. So,
He's had years of education
Yeah,
listening to
you're
the
an
Beauty and the
amazing
Surgeon
dude.
podcast. He's gone
you're
to
a, you're a producer and plastic surgery fellow.
Bat School of Medicine.
Like the other Dave. So that closure is important. We put drains in. And what I do at the end of the procedure is I add a bunch of staples externally. Those come out early. But what do staples do? And it was like hilarious because our patient in the hospital now said this. When you pull too much or you sit too hard, the
Staples hurt.
pull and it hurts. And she actually popped one of those out. She was
Yikes.
really concerned. I know that's kind of hard to do.
It's hard to do. Like you got really tough through that.
She was very concerned about it. I'm like, don't worry, you have 1,000 more in there.
Yeah, it's not the only one.
Yeah, I put a lot for that reason. And
I doubt she actually popped it. I bet it was one of the ones that wasn't actually attached and it just fell and she.
Of course it was. Yeah.
Yep, thought she'd lost it, but
It was funny because the nurse came in and the nurse was like, yeah, I looked, there's a lot more left. I was like, yeah, that's the point. So
there's a lot more.
yeah, I mean, I think that 72, we've talked about this many times before. Okay. There's healthy 72 and there's not healthy 72. If you don't have a lot of comorbid conditions, diabetes, high blood pressure, you're not a smoker, you're active, you don't have any problems with your heart, you are healthy, you focus on nutrition and exercise, and you have definitive issues of the thigh, both fat and loose skin, then you 100% would be a candidate for this procedure.
And it's not like it's a super risky procedure. I think the biggest thing, as we talk about on our thigh lift videos, is that like the slide that I call like extra or special considerations is you do need more help after this surgery than others. And that would be the only thing, making sure that you have a really good support system for the first week.
And that usually does not involve significant others like husbands.
Yeah, probably not your spouse, but like a child or a good friend, someone who can really help you that first week is going to be really key. And it's possible, if you've had consultations with a plastic surgeon, it didn't seem like it from this text, but maybe since then, you may not need a thigh lift. You may just have to accept that you'll have some sagginess, but you can get rid of the fat. And that alone might be enough of a change to improve the way it looks in clothes. If you're looking for improvement without clothes, the thigh lift is probably more necessary. But if you're like, it's just a little bit, it's at the very top, the inner thigh, even in shorts, maybe it would be fine.
You could out those knees. You could do a mini medial thigh lift.
And just some liposuction of the knees.
Which I don't even know if that surgery exists, but I just like the idea there's a mini medial.
Yeah, I think we've kind of done that before, almost like a posterior thigh lift, where
but you could do it anteriorly.
You could do it that way too.
Just
wherever people tend to have more
with
laxity
a little body
on the back.
tie. We're creating a whole new surgery for you, Patricia. Just call us up. We're gonna call this the Patricia maneuver.
Yeah. So, how do you poop after surgery? Any way you can find comfortably.
Yeah, it's not great.
Yep. And it really for the first. Oh gosh, truthfully, and this is just me being extremely honest, for several months after surgery, you're not going to feel comfortable sitting on a very hard surface at a 90-degree angle. You're just not.
And urinating too is a problem.
Exactly.
Like our patient in the hospital urinated on her dressings, so I took those all off today.
And that's where the female urinal, it's a little funnel essentially that you pee into and shoots it into the toilet.
And you do that in a standing position?
You do it standing, and it also is going to make sure that there is no moisture that's hitting your incisions because it's funneling it all straight down.
Yeah.
Yep. So
the problems with medial thigh lifts, I know this is not one of the questions, but the problems with medial thigh lifts, if you don't inset the suture line or the incision line correctly, is effacement of the labia, which can be really problematic, or stretching out of the labia, which is not natural and normal. So when you inset the closure, you really do it to areas of strength, the fibrous areas in your pelvic floor and even the fascia surrounding the muscle of Amy, the muscle was gracilis and sartorius. And you like sartorius best. I like gracilis best. It's kind of has that East Coast, West Coast muscle thing going on.
Yep.
And I said it was the graceful muscle with the Taylor.
Yeah. And I called it the hacky sack muscle.
Very good.
Gracilis. Yeah.
So those deep sutures, if you close it, you have to do it this way. You don't have a choice. So, the surgeon's going to have to close it this way if you want it to heal correctly. Those deep sutures really do hurt too. So you can have 3 weeks out where you kind of do a maneuver and you feel like burning pain. And that's a lot of times that comes from those deeper sutures and you're really putting a lot of pressure on the wound.
Yep.
So it is a process to heal from this.
Yeah, but you're making it sound worse than it is.
I feel like it's one of the harder ones to heal from, not pain-wise, just
lifestyle. Doesn't mean you need a lot more help. You need to have more special considerations for longer.
Okay, that's probably a better way to put it. Yeah, it's not by any means super painful. The posterior body lift, which is like basically an incision at the top of your butt all the way around to your abdomen on both sides, and a medial thigh lift patient is off pain medications on postoperative day number 2 and taking Tylenol.
Yep, it's not super painful. But after any surgery, 3 weeks later, you can do something weird and feel pain.
Yeah.
It's not like it's different in that sense, just it's deeper. And
I never get those phone calls. Amy has to answer all those.
I get those all the time. So.
I'm always in the OR.
Yeah, I'm always in the OR. Nice. All right. So.
Sucker.
Our next question this was.
How was that phone call, Amy?
It's constant. I don't even notice anymore.
You're like punch drunk.
No, it's just the thing. This is just questions people have. It's not unusual. That's what I'm just trying to say.
I'm joking.
All right. So our next question was actually a really great question. This was from Mary, also on YouTube. Is a person who had most of their lymph nodes removed from under their arm a candidate for a brachioplasty?
This is a tough question.
It is. And that's basically what I responded to her, is that it really depends. Having lymph nodes removed does not preclude you from having a brachioplasty. But we need to know more. This is not a yes or no answer.
Right. So when you have lymph nodes removed, in almost all cases, not all cases, but the majority of the cases could be for breast cancer.
Or some type of cancer.
Yeah, but usually breast cancer. Yeah. It could be maybe a melanoma or a skin cancer that you worry about it going to the lymph nodes. But by and large, for females, it's going to be a breast cancer surgery. So breast cancer is a real common cancer in women. It's now 1 in 6, 1 in 7 women. The treatment is removal of the cancer, either by a lumpectomy or mastectomy. 1 in 5 now. Yeah, it's so terrible.
Yeah.
It's just devastating.
It is, especially when I work in an office with 4 other women. I'm like, wow, it's one of us.
One of us, I know.
Mm-hmm.
Well, I'm basically a woman now, so you can throw me in there. So.
No, you don't have. You don't get to steal this one thing from me.
I don't get to steal breast cancer.
You don't get to steal breast cancer from me.
Okay.
You know what I do think? I mean, very often though, I think like, man,
men get breast cancer, by the way,
yes,
3%. And then if you have BRCA1 or 2 genes, and you're a female and you have a brother who hasn't been tested, they need to be tested.
Or a son.
Yeah, because their incidence is very, very high, even though it's rare in men. Go ahead, sorry.
No, you keep going. So
anyway, so you do a lumpectomy or a mastectomy. Mastectomy is removal of all the breast tissue that can be nipple or non-nipple sparing. Lumpectomy is removal of the breast cancer. Almost always associated with that. There's a few cancers where you wouldn't care about the lymph nodes, but almost always you're going to sample the lymph nodes, and that's called a sentinel node biopsy. You inject a radioactive substance underneath the skin near the nipple and areola, and that tracks to the first node that drains that breast. You can also do dye. There's different types of dye you can use, and there's a few other techniques, but you sample those nodes, the nodes that drain the breast. And that's if there's cancer in there too, breast cancer in there too, then you know you have to do other treatments, usually perioperative chemotherapy and definitely radiation, even if you've had a mastectomy. So it's hard to know what kind of lymph node removal you had.
Yeah.
If it's a sentinel node biopsy, that could only be 1 or 2 or maybe 3 lymph nodes, right?
I should say most.
But when you get into a more invasive lymph node dissection, and there's different levels, level 1, level 2 lymph node dissection, underneath the pectoralis major muscle, different levels of removal, the incidence of lymphedema, and this is really important, goes way up. You can get lymphedema with a sentinel node biopsy, but it's pretty rare. And per memory, it's like 5% range or less than 10%.
And it usually resolves. It's usually like
a transient.
Yeah, transient.
Yeah, but I've seen it. And it definitely, that incidence will go up with radiation. But in this situation where you've had a lot of lymph nodes removed, I would be really weary of doing the brachioplasty then. Now, that's my judgment. Other people may feel differently. I feel like that would put you at risk for lymphedema in that arm. Now, with a brachioplasty, I don't think you're disrupting a lot of the lymphatic drainage because that's going to be a little bit deeper, okay? And it's more of a superficial procedure. Whereas the breast cancer procedure that takes lymph nodes out obviously disrupts the lymphatic drainage, both of the arm and the breast. So I think you could do it and maybe be okay, but I would be really concerned about that. I really would.
Yeah, and I would want to know too how far out you were from the lymph node removal. I mean, if it had been 10 years or more and you'd never had issues with lymphedema and you could get away with doing like just skin and no liposuction with your brachioplasty, because again, liposuction is going to disrupt the lymph far more, staying completely out of like the axillary area and just doing like a skin excision only. There could be options there even if you've had a lot of your lymph nodes removed. Now, if you're only like 6 months or a year out from this lymph node removal, I mean, that I'm with you, like, because you don't know still what might happen.
What would be
I
devastating?
apologize if anybody else can hear that beeping noise. I don't know what it is, so I apologize. Or if I'm the only one who hears it.
Yeah.
Okay. I'm like, something's beeping somewhere. Okay. Like, I hear it. People would be like, they're just not going to talk about the beeping.
Yeah. You're totally fine.
The beeping has stopped.
Is it the voices?
Right. It's not voices. It's just beeping. If only they were talking back.
So what would be devastating is if you did the brachioplasty and then developed lymphedema afterwards.
Which, I mean, hypothetically, you could potentially get lymphedema from a brachioplasty alone.
You can get lymphedema from anything.
Right? It can be idiopathic. It can just start.
To be honest with you, these patients are told not to even have IVs put in their arms on the side of the mastectomy. And that's a little bit archaic in terms of recommendation. It should be more mastectomy with lymph node sampling, but in almost all cases, you're doing lymph node sampling anyway, so I think it's just easier to say mastectomy.
Yeah. I mean, if you've ever seen someone who has true lymphedema in a limb,
devastating.
It really is. And
Yeah.
I mean, there are things you can do to help. You can do taping, you can wrap it, you can have physical therapy or occupational therapy.
They actually do lymph node transplants now, which
Are those effective?
it's so funny. That's after my training. There's very few things in plastic surgery that were after my training, and that was one of them. And I was at some conference, and I met a younger plastic surgeon, and it was the first time I felt a little older, because he's like, yeah, I'm going to focus on lymph node transplants. And I was like, oh, that's really cool. And I was like, what the fuck are lymph node transplants? Sorry for my language. I was like, when did that start? And then I, of course, asked him 1,000 questions about it, which was very interesting. And it definitely helps. It can definitely help. It doesn't solve the problem.
It's like putting in a stent, like a brain stent.
No, but it's pretty interesting. And the method of transplantation of the lymph nodes is pretty interesting. I'm not sure. Again, this is not our expertise nor our knowledge area. I'm not sure if what the recommendations are about transplanting lymph nodes into an area that conceivably had breast cancer.
Right.
I can't imagine that's not going to happen, and especially if it's been radiated. Why even transfer the lymph nodes in there? But if she didn't have radiation, she had radiation. If she had a lot of lymph nodes removed and she had breast cancer, she had radiation. I would pretty much guarantee that. But if they didn't have radiation, and it's the lower extremities or upper extremities for whatever reason, lymph node transplantation is the answer right now, which is really interesting.
Yeah. So, Mary, like I said in my response, it doesn't preclude you from having a brachioplasty, but you definitely need to meet with absolutely only a board-certified plastic surgeon and just find out more. They need to know a lot more about your past medical history and everything else. So.
And then also if you do have lymphedema, even mild. Some people can have mild lymphedema, and even that alone would prohibit you from healing well from a brachioplasty.
Yeah. Awesome. That's it. So again, I love questions from listeners because I don't know. I mean, some of these, we've never been asked some of these questions before, which was awesome.
No.
And brought up some things that we could talk about also. So I'd love it if you would leave us a voicemail or send me a text or just leave a comment on this video to be featured in one of our next episodes of questions from listeners. Because these are always so helpful. And they're so much fun to listen to because they're just very interesting. So, and again, the timestamps. So if you want to find your question specifically, I should have said that at the beginning, there's timestamps. So you can find your question or you can find the question you're interested in listening to.
Yep.
All of our social media handles are here yet again. 303-630-9038 is our phone number. I'll tell you who has found the phone number is the Google bots because they spam call me. I mean, I'm not kidding. I think the other day I had like 15 missed calls, all from like 3 different numbers, and they're all spam. Like there's no one there. So someone's calling me. It's just not our listeners.
It's AI. AI is trying to take over our podcast.
Yep. They need to redo that song London Calling and make it AI calling. Where's Weird Al when you need him?
I think the best thing about listener questions is that just the viewpoint is so different than the way my brain works as the surgeon and even yours as the recovery specialist. You know what I'm saying?
That's what I mean. Yeah, there's questions that we don't know people are wondering about.
Right, which I love that. And it helps me as a clinician. It helps me to help my patients because then you can understand, oh, wow, that's a different way to look at this or that angle. Like even that brachioplasty question really gets me thinking about if I ever see patients who've had lymph node biopsies, even having that conversation with them. I would never think of that, you know? So very interesting. Yeah. So thank you so much for listening and for all of you who sent questions. I really appreciate it. And I hope that we found the answers helpful. Yeah. We'll see you next time. Yeah. And next time we're going to have at least 10 different voicemails, messages. That would be a 2-parter. Yeah. See you later. Don't forget to check out our sponsor, Let's Get Checked. Let's Get Checked offers fast, affordable, and completely confidential health testing for everything from STDs, male and female hormones, and even COVID-19, right from the comfort of your own home. And remember, new customers and listeners of our podcast get 20% off by using our URL, trylgc.com/beauty, and be sure to use the code BEAUTY20 at checkout. That's trylgc.com/beauty and use the code BEAUTY20, beauty, BEATUY 20 at checkout. Get checked. It's the right thing to do.